Okay, so we've changed the journey for our frail patients. So our patients, instead of going into ED and then going into the lottery of the entire system as to whether they from there were transferred onto general medical wards or care of the elderly wards or ED or AEC, anywhere. Instead of that, they're being streamlined to this frailty unit now, where once here they're having a one-stop approach. So they're being seen by the consultant geriatrician, the physiotherapists, the occupational therapists, and anybody else that can be involved or improve their journey. Pharmacists are also getting involved to do medicines reconciliations and also to be able to advise what they can do with medicines at home that they no longer need. We've had pharmacists arrange for community pharmacy teams to go in and collect any unwanted medicines. The purpose of this is that patients are seeing everybody all in one go, and they're getting a complete holistic assessment. They're also having a complete geriatric, well, your complete CGA, aren't they? So they're being assessed right from the start. They're having everything assessed all in one place. And it means that we can look at it completely and not just look at the medical side of the patients. The idea is to try and prevent our patients from spending too long in hospital or actually avoiding unnecessary admissions altogether. So they're coming in, hopefully we're being able to sort out their problems and sending them straight home again. And if not, they've already seen all the people they need to see, so they've got plans in place so that when they do move on to one of our frailty wards, there's a continuity there. The plans are already in place, those plans can carry on, and hopefully their length of stay is vastly reduced. We don't want our patients spending any longer in hospital than they need to, because once in hospital they tend to be very vulnerable to sort of deconditioning, spending too long in bed, not getting up, dressed and moving. And we don't want that happening to them. We want them home and in their environment and where they want to be as soon as possible.
How do you identify the patients as they're being admitted? Is that done by the ambulance service or the GP, or are you doing it at ED?
At the moment, the ambulance service are sending their patients to A&E unless the GP has identified them as an admission, in which case they've spoken to one of our consultants already and they can come here straight away. Once in ED, though, we've got ACPs that specialise in frailty that are identifying the patients as frailty patients and pulling them straight through. So we're vastly reducing the length of stay that our patients are getting.
Yeah.
Sometimes by days, sometimes just by hours, but it's all being reduced.
And is that done on like an EFI score or a frailty index of some sort? Or?
They begin the comprehensive geriatric assessment actually in the A&E department, and providing they don't need any other specialist input, their investigations are started straight away. So by the time they're pulled through and they see the geriatrician, those results are all ready, and we've got a much better view of what we can do from there.